Uh, a very good morning to everyone, to the respected faculty members and my dear colleagues. I'm Dr. Urvi Patel. I'm the second year DNB critical care resident at Zydus Hospital, and I am being given the opportunity to present the Surviving Sepsis Guidelines 2021. So today's objective for the lectures are what's new in the Surviving Sepsis campaign 2021, what is the current understanding of sepsis, the novel therapies and the newer vasopressor agents, and the role of the extracorporeal therapies in the sepsis. So basically, the Surviving Sepsis campaign or the has been launched long back ago in 2002 in the Barcelona Declaration, and then the first guidelines were there in 2004. Firstly given as a 6 hours management bundle and 24 hours management bundle, and every 4 years they are renewing the guidelines, giving a new recommendation. So the latest guidelines are given in 2021 with the 2018 sepsis bundle, which is the hour 1 management bundle. So what is being new discussed in the Surviving Sepsis Guidelines? So basically the Surviving Sepsis Guidelines in 2021 is focused on the medical professionals, the nursing staffs, the policymakers. They have a new focus based on screening and resuscitation, the infection control, the hemodynamics, ventilation, additional therapy, goal of care, and the long-term outcomes and recovery of the sepsis. So these formulations were based on the evidence to decision framework, which not only takes into account the quality of evidence, but the effect on the patient's values, the resources required, the acceptability, feasibility, and considering the cost. The recommendations which are given were based on the weak recommendations, strong recommendations, no recommendations, or the best practice, which have a close balance between the desirable and undesirable effects of the recommendations and the substantial resources which are required for the interventions. So in 2021 guidelines, they have given 93 statements. 54 are the weak recommendations, 15 are strong recommendations, 15 recommendations are given for the best practice statements, and 9 statements which have no recommendations. So if we see that though the sepsis is much prevalent condition in the ICU setups, there are many practice-based variations and uncertain questions which are developing in the mind of an intensivist, like when to determine a patient with sepsis, or when can you say a patient, what criteria should be used in a patient to be declared as in a septic or septic shock, what kind of fluid should be given, what kind of how much fluid should be given as an initial resuscitation fluid, or what should be the strategy for using albumin, or what should be the mean arterial pressure, what and the target for achieving the MAP, and what target timeline should be given for the administration of antibiotics, and how much empirical coverage should be done, dual coverage or monotherapy. And all these were the questions with uncertainty most popular. So these all are addressed in the current Surviving Sepsis Guideline of 2021. So today on this lecture, we will be discussing what are the main strong evidence-based recommendations given by the 2021 guidelines. So first, if we are seeing a patient in the emergency, and we have to admit the patient to the ICU. So Q so far up till now was used as a single screening tool for the rapid risk stratification of the patients admitted to the ICU. So in 2021 guidelines, they are against the single use of Q-SOFA as a single screening use. They now recommend it to be used with along with other scores like CERS, NEWS, MUSE, and it is a strong, moderate, quality-based evidence. So they are against the use of Q-SOFA as a single screening tool, but it can be used as a prognostic information along with other tools. So if we are seeing the evidence of Q-SOFA, so there was a quick comparison in a systemic review and meta-analysis with CERS criteria. So if we are seeing the Q-SOFA score is very good for prognostication of mortality, but the evidence for diagnosis of sepsis when compared to search, it is less. If we are seeing, the second question comes is, what should be the initial fluid management? So in 2020, 2016, it was said that 30 ml per kg intravenous fluid should be given within first 3 years. So the PICO question was, in a case of known or suspected infection and hypertension with elevated lactate, should we administer 30 ml per kg of crystalloid or a rapid volume fluid challenge and reassess? So it is a weak or low quality of evidence. In 2021, we suggest that at least 30 ml per kg of IV crystalloid fluid should be given within first 3 hours of resuscitation. And this 30 ml per kg IV fluid recommendation has been derived from the trials which are going on, like the PROCESS trials, the PROMISE trials, and the ARISE trials. And most of the patient here with sepsis-induced hypotension will at least need this much amount of fluid. And again, this guidelines, they recommend that the fluid strategy should be based on the clinical status of the patient, considering the clinical status of the patient. So they have down-regulated the 30 ml per kg resuscitation from a strong recommendation of 2016 to a weak, low quality of evidence in 2021. If it is an ongoing resuscitation, so how much fluid should be given after the initial 30 ml per kg crystalloid bolus fluid? Should it be a fluid liberal, or it should be a fluid restrictive resuscitation? So in 2021 guidelines, no recommendation is being used for the fluid liberal versus the fluid restrictive strategy. Again, it has emphasized on using the dynamic measures to guide the fluid resuscitation over the physical examination, and also like the measurement of the SVV, PPV, the passive leg rising test. It on the basis of the serum lactate is now considered to be a weak recommendation with a low quality of evidence. It is said that serum lactate should be used in consideration, not as a single tool for prognostication, but it should be considered with the clinical context, and the other causes of elevation of lactate should be taken into consideration. And the lactate again can be used for prognostication. If we are considering the mean arterial arterial pressure, so the target for MAP in this patient is to be achieved 65 mmHg. And in the patients with chronic hypertension, it suggests to achieve a higher MAP more than 65 mmHg. They have taken into consideration the capillary refill time, which was a weak recommendation. This is taken from the Andromeda shock trial been recently conducted, and it is also it was taken into account the capillary refilling time versus the lactate. So the 28-day mortality was comparable between the two. So the capillary refilling time was used to guide the resuscitation along with the other measures of perfusion, and it is considered to be a weak, low quality evidence. Coming to another point, PICO question, which fluid should be used for the fluid management in the first 24 hours? So in the 2016 guidelines, it was not taken into account. This is there is always a controversy whether to use the balanced fluid against the 0.9% normal saline. So based on the SMART trial, which was conducted, which was considering the endpoint as a 30-day mortality, randomizing the patients between the balanced fluid versus the saline fluids. So based on the SMART trial, the basic trials, now they are considering the balanced salt solution instead of the normal saline solution for resuscitation. But again, it is a weak, low quality of evidence. And if we are considering giving the patient albumin, then in the 2021 guidelines, it is said that if the patient with septic shock who has received a large volume of crystalloid only should be given albumin. Again, it is a weak, moderate quality of evidence. If we are considering other colloids like the starch or the HES, then the recommendation is against the use of such gelatin or starch colloidal fluids, and it is a highly quality evidence and a strong recommendation in the 2021 guidelines. So after the initial fluid resuscitation and the ongoing resuscitation, we now come on to how to maintain this hemodynamic stability in such patients. So after giving the fluids, if the fluids on adequate resuscitation is not maintaining, we can consider albumin as a colloid, and then we can consider adding the vasopressors. So first vasopressor which needs to be added is norepinephrine, followed by vasopressin. And in case of septic induced cardiomyopathy, even can be dealt with dobutamine or epinephrine. And arterial blood pressure monitoring is essential for these patients with septic shock. And whenever we are receiving the patient with septic shock, up till now, we used to give there was an practice of giving the vasopressors only through the CVP line and avoiding the peripheral vasopressor initiation. So in the 2021 guidelines, now they has recommended to give the peripheral vasopressor initiation because of the complications associated with the central lines. The issues which are faced with placing the central lines, there will be a delay in the starting of the vasopressors if we are starting the vasopressors only after inserting the peripheral central line. So the peripheral lines can provide a safe and less invasive access for the short-term use if we are using the vasopressors for less than 24 hours, or if we are using only one vasopressor at a time. Then they have even considering the push doses, minimal doses like epinephrine can be given at a dose of 15 to 25 microgram per minute. Dopamine at 12.7 microgram per kg per minute, plus or minus 5.2, and phenylephrine 2 to 3.25 microgram per kg per minute. Low dose push dose vasopressors can be given to the peripheral line. And they have even given how much amount of time the peripheral vasopressors can be given. The duration should be less than 24 hours to minimize the extravasation and the complications which are related with the peripheral vasopressor initiation. Even one study has given maximum norepinephrine duration through the peripheral line should be only 4 to 6 hours. So which pressure should be considered for the push dose pressures? If the time taken for insertion of peripheral line will be more than 1 hour, if there is any contraindications to insertion of the central line, if the central line are not available at the institution, the vasopressors need anticipated is to be used only for less than 24 hours, and only one vasopressor is to be used. So 2021 guidelines, they have taken into account the resource management in both the high resource and the low resource setting. So coming to the vasoactive management in the septic shock patients, the first vasopressor recommended by the 2021 guidelines, strong recommendation is norepinephrine. There is high quality evidence against the use of dopamine in the 2021 guidelines. And as an alternative to dopamine, we can consider using epinephrine. So in the 2021 guidelines, they have given to achieve a MAP of 65 mm Hg, and vasopressin should be initiated at a norepinephrine dose of 0.25 to 0.5 microgram per kg per minute. So they have considered adding vasopressors despite low to moderate dose of norepinephrine if the MAP is inadequate. And after considering norepinephrine, vasopressin, recommendation for adding epinephrine is a weak recommendation, a low quality based recommendation. And in case of cardiomyopathy, dobutamine should be considered. Considering the other vasopressors like the celepressine or the angiotensin 2, it is a very weak recommendation with a low quality of evidence. And the 2021 guidelines is against the use of terlipressin in the patients with septic shock. Now, once the patient is started on the vasopressors, the de-escalations of the vasopressor should also be taken into account. So there are several studies for de-escalations. Some studies says that norepinephrine, if de-escalated first, will result in more hypotension. Some study have an evidence that if vasopressin is being de-escalated first, then it will result in more frequent and early hypotension. So recent evidences are telling that the norepinephrine and discontinuation will cause more incidence of hypotension as compared to vasopressin, and shock reversal will be more following the first um, discontinuation of vasopressin as compared to norepinephrine. So after considering for the fluid management, the vasopressors, now the PICO questions arises regarding whether to use corticosteroid with such patients with septic shock. So in 2016 guidelines, it was against the use of IV hydrocortisone to treat the septic shock patient. In the 2021 guidelines, now we recommend, there is a weak recommendation in the favor of using low dose corticosteroid. It is considered that if there is ongoing sepsis, septic shock on ongoing vasopressor therapy, that is, it is a refractory shock, then we should consider the corticosteroid therapy, as it desirable effects are outweighing the undesirable effects. And so there is a low dose corticosteroid therapy weak recommendation in the 2021 guidelines. Also, the question regarding the use of vitamin C is always in a dilemma, whether we should use vitamin C in a patient with sepsis or septic shock. So in the 2016 guideline, there was a new recommendation regarding the use of vitamin C. But in the 2021 guidelines, after the ongoing studies and the meta-analysis, they have now come against the use of using the IV vitamin C, and it is basically a weak recommendation with a low quality of evidence. So after the initiation, now there is timing for the antibiotic administration. So basically in the 2021 guidelines, the shock is defined as either it can be a definite shock or a probable shock, or either there is a possibility of sepsis. And considering sepsis with the presence or absence of shock, we have to determine whether we need to administer the antimicrobials within 1 hour, or we need to wait for the assessment of the infectious versus the non-infectious causes, and can if in the strong possibility of sepsis, we can administer the antibiotic within 3 hours. So basically, if the sepsis is definite or probable along with the presence of septic shock, then we need to administer the antibiotic within 1 hour of recognition. Even if there is absence of shock, but we are there is a definite sepsis or a probable sepsis, also then the antibiotic microbial should be given within 1 hour. If there is a possibility of shock, sepsis with septic shock, then also the antimicrobial should be started within 1 hour. But if there is only a possibility of sepsis with no ongoing shock, then we need to first rapidly assess the patient to rule out infectious versus non-infectious causes of the active illness, and then considering we can administer within 3 hours. So if In the 2021 guidelines, there is a weak recommendation saying that if the patient is presenting with definite sepsis with the septic shock, then we have to consider giving empirical MRSA coverage, considering high risk of infection. So, which patient should be considered at high risk characteristic for MRSA? Either the patient has a prior MRSA infection or colonization, either the patient has received an recent IV antibiotic or has history of recurrent skin infection or chronic wounds, is patient on invasive devices and hemodialysis, recent hospital admission, considering the severity of illness, and if the hospital unit has isolates of MRSA on the culture reports. We should also consider the multi-drug resistance pathogens based on the preceding year proven infection or colonization in the ICU. That is a local prevalence of the antibiotic resistant organism in the given ICU. The nosocomial versus the acquired community infection. If there is a use of broad spectrum antibiotic within the last 90 days, if there is a history of travel to highly endemic areas within the last 90 days, and if the hospitalization abroad was given within the last 90 days. Also, considering for the fungal infection and starting appropriate antifungals, if the patient has received a broad spectrum antibiotics for more than 7 days and there is failure to response, there is immunosuppression or neutropenia. If the patient has comorbid conditions like diabetes, is on the TPN, or has GI perforations. The guidelines also recommend to optimize the antimicrobial doses based on the pharmacokinetics and pharmacodynamics, because many of the patients with septic shock will have AKI, acute kidney injury and acute liver injury, and many of the antimicrobials have an hepatic metabolization and the renal clearance. So basically, the physical derangement and fluid resuscitations, they will increase the volume of distribution of the antimicrobials. So the hydrophilic antibiotics like the beta-lactams, the vancomycin, or aminoglycosides, they require loading dose for such patients. Also, the patients with septic shock most often have hypoalbuminemia. So the drugs which have good plasma protein binding, they will remain unbound, and there will be an increase in their volume of distribution and their clearance. So for such drugs, we can lower or suboptimize their concentrations. And whenever we are having use the vasopressors, it will augment the renal clearance. So there will be an increased renal perfusion. So it will have a treatment failure. So in this condition, we need to optimize the dose of the antibiotic. And also we need to assess and identify the source of infection. And if the IV devices are there, considering them to be a probable source of infection, we should remove them as early as possible. And daily assessment for the de-escalation of the antimicrobials should be done, is recommended in the 2021 guidelines. So after the antibiotics, we now go towards the ventilatory part. So in the 2021, there is a new recommendation for using HFNC. It should be, that is high flow nasal cannulation, used in patients with sepsis-induced hypoxic respiratory failure rather than the non-invasive ventilation. And it is a new weak moderate quality of evidence. Even now, they have considered the use of veno-venous ECMO when the conventional ventilation fails in the new 2021 sepsis guidelines. There are no recommendations on the use of neuromuscular blocking agents. It is said that it can be either given as intermittent boluses over the continuous infusions. So coming to the long-term outcome and recovery part of the sepsis. Up till now, there are no such recommendations on the outcome or the recovery. There is no discussion upon the economic and social support, the nutritional, financial, the spiritual support of the family. The 2021 guideline has now given the recommendation on the active participation with the family regarding ensuring the discharge, regarding the financial, spiritual, and nutritional part, regarding the reconciling of the medications, from shifting of the ICU to the wards and from the wards to the discharge time, and regarding the discussion of the sepsis and the treatment ongoing and the ICU stay and the post ICU or the post sepsis syndrome in a written and verbal hospital discharge summary along with the families of the survivors of sepsis. They also recommend that there should be a new long-term sequel discharge plan being discussed with between the clinician and the family. So now the 2021 guidelines recommend assessment and follow-up with the physical, cognitive, and emotional problems even after the hospital discharge. And some of the basic issues regarding the handling of the information and the handling of the care process from the ICUs to wards are also being given big recommendations in the 2021 guidelines. So basically, the goal of care aims at discussing the goal of care and prognosis with the patient and the family, and providing an opportunity to the family to even participate in the shared discussion making. For the first time, they have considered this shared decision making in the 2021 guidelines. Regarding the transition of care, it is recommended to use a handoff process of important information for the transition of care, because many of the time there is a lack of information from when the patient is shifted from the ICU to the wards, and use of the critical care transition program whenever we are transferring the patients or handing over the patients from ICU to ward. And it has also emphasized on considering for the palliative care and addressing to the patient and the patient's family regarding the symptoms of suffering. And also the 2021 guideline has newly recommended for giving the education both in written and verbal orders for the diagnosis and treatment and the hospital discharge and follow with the patient's relative. So these were some of the new recommendations which were being discussed in the 2021 guidelines. So basically 2021 guidelines from the recognition of sepsis to the screening and initial resuscitation to the ongoing resuscitation, the antibiotic therapy, ventilation, and lastly, the goal of care and discharge and follow-up plan all has been covered in the 2021 guidelines. So the 2021 guidelines was basically framed on the early sepsis bundles. Whatever recommendations were given in the early sepsis bundle guidelines, like the initial lecture drawn within the 3 years, they all have been considered as a guidelines in the 2021. From the early sepsis bundle to the additional sepsis element, like the first line vasopressors, the fluid resuscitation before or concurrent to the vasopressors, the use of adjunctive steroids, whether it be a dilemma between the balanced solution or the saline, and what is the antimicrobial recommendations, and the lung protective strategy for the patients with septic shock, like recommending a low tidal volume ventilation of 6 ml per kg over a high tidal volume strategy of 10 ml per kg, and even considering the use of HFNC and VV ECMO in the patients with septic shock who are having sepsis-induced respiratory failure. And even they have taken into account the recovery part of the septic element on the survivors. So now let us discuss some of the novel therapies. Up till now, we have been emphasizing on the early diagnosis, what antibiotic should be used, what should be the hemodynamic support, or the ongoing vasopressors. And all these interventions have also led to decrease in the hospital mortality and have given a very good uh, result in sepsis. But as the researches and the trials are going on identifying the various um, identifying the various markers which are involved in the immune system, be it the innate immune system or the adaptive immune system, and the specific therapy which are targeting this markers involved or cytokines which are involved in the sepsis. Is my voice audible, sir?
Yes, Urvi.
Okay.
Please go on.
Thank you, sir. So nowadays, with the ongoing research on this biomolecular triggering agents, which are causing such uncontrolled inflammatory response, and the pathological inflammatory cascade at the molecular level are being studied, we now need to have an approach based on these novel supportive therapies, which are being either used as an agonist against these markers which are involved in the sepsis pathway. So once the patient has any ongoing infection, it will lead to inflammatory response. It will lead to activation of the innate immune as well as the adaptive immune system in the host. And this innate and adaptive immune system is being regulated by many of the markers, be it the cytokines or it be the interleukins or complement C5a or the C5a receptor, or it be the derangement in the coagulation, which is leading to the DIC component in the sepsis patient, and the activations of the phagocytes, macrophages. And also nowadays, the treatment is being shifted towards targeting the uh, genomics, that is the HLA expression of the host cells, because every patient with sepsis is having um, uh, different response to the pathogen. And some of the patients will recover within a time, but some of the patients uh, go on detouring with the same treatment management. So there are certain markers which have fluctuations in such patients, which are leading to the diversity in the outcomes of the survivor versus the non-survivors. So this is basically the slide showing the different pathogens which are involved in the innate, in the adaptive immunity. So in the innate immunity, it is mostly considering the uh, phagocytic cells, B cells activation, or the macrophage involvement, the neutrophils, the dendritic cells, and the antibodies like IgG, IgM, and IgA, and the adaptive immunity considering the immunoglobulins and the cytokines, the complement system, the endotoxins released, which are responsible for the uh, septicemia. So why we need to study the biomarkers in the sepsis? So we need to firstly identify the biomarkers, whether it is having any utility or is it is a futile marker in the sepsis. We need to measure these biomarkers. We need to stratify the severity of the biomarkers, and we need to use these biomarkers for the prognostication of the sepsis or the ongoing septic shock. So what can be a perfect biomarker? So if we want to label a biomarker as perfect, it should have high sensitivity and specificity. It should allow the differentiation between the infectious and the non-infectious cause. It should have good prognostication value, and it should be easy to measure and have a low cost. Against the conventional diagnosis which we were using, like the detection of the gram-negative bacteria or the gram-positive bacteria on the culture reports, and determining the antimicrobials based on these culture reports, and many a times which are landing up in an uh, landing up in the resistance against of the antimicrobials. So basically, the ideal biomarker should have a fast kinetic, low cost, short turnaround time. It should be linked to the main underlying process. It should have a point of care test, and point of care test is much now being emphasized in the critical care, and it should be highly specific and sensitive. So these are this summary of the biomarkers from the innate response biomarkers like the pathogen-associated molecular patterns or the damage-associated molecular patterns, the calprotectin, the cytokines and chemokine, which are involved like interleukin-6, the monocyte chemoattractant protein, pentrexin, the receptor biomarkers like prepsin, CD64, or the soluble triggering receptor expressed on the myeloid cells, or the PD1 receptors and ligands, or the TLR receptors. The microcirculation related biomarkers like the angiopoietin 1 and 2, or the andromodulin and the promodulin biomarkers, and the biomarkers which are leading to the organ dysfunction like the microRNAs or the long non-coding RNAs and the matrix metalloproteases. So now we will study the novel innate response biomarkers. First, we would study the basic pathogen-associated molecular patterns and the damage-associated molecular patterns. So basically, these biomarkers have activation as an innate immune response, which is basically triggering the pattern recognition receptors on the host cells, and they are basically the molecular warnings markers, which are activating the circulating and the resident immune cells in the host system. So basically, to detect the PAMP, the molecular base assay is detecting the pathogens and the pathogen materials from the blood or the localized fluid from the specific organ side if available, and using the multiplex detection by the PCR or the FCMBL based blood assays. They are been currently realizing the point of care diagnostic, and also the identification of the PAMPs will help in the therapy of PAMP removal. PAMP removal can either be due to some of the novel drugs which are targeting the pathogen-associated molecular patterns like the liposomal agents, and also these PAMPs are now said to be cleared by some of the recent extracorporeal blood purification methods also. So the PAMP removal will have benefit in improving the hemodynamics, improving the mortality of the sepsis patients, and but the concern is the different mechanism and the targets. So basically, one of the drug which we are considering for targeting the PAMP is a liposomal agent. So the liposomal agents is basically the artificial liposomes are basically built to neutralize the bacterial toxins which are either released from the gram-positive bacteria like the Streptococcus pneumoniae, which will release the pneumolysine, and the Streptococcus pyogenes, which is responsible for the streptolysin O release. And these toxins are responsible for the ongoing toxemia and ongoing cascade of the septic shock. So the liposomal agent which is being discovered is the CAL02, which is a novel antitoxin agent considered as a mixture of liposomal, which is creating a large and soluble, stable lipid-ordered lipid microdome, which is trapping the bacterial toxin. And its half-life is roughly around 6 hours, and it is not impairing any kind of microcirculation because of its very small size and molecular weight. And one of the recent study in the ICU only on 19 patients was done in the patients with severe pneumococcal pneumonia, where they have considered giving low and high doses versus the placebo. And there was a reduction in the organ dysfunction. But I don't know how much this study is reliable, because again, there was a small sample size. So it is not appropriate to comment on the use of CAL02. But hence, we need a larger data support from the larger clinical trials to confirm the clinical value of using this adjuvant therapy against the pathogen-associated molecular patterns. And also, it is said that the CAL02 had a very rapid decline in the CRP and the PCT-like markers of sepsis. Coming to the second marker of sepsis, that is the calprotectin. It is one of the most abundant calcium binding protein which is being found in the neutrophils cytosol. And they have been considerably increasing within hours in response to the bacteremia or the toxemia. And it is said that calprotectin levels is directly correlated with the 30-day mortality. And for determining the superiority of the calprotectin against the other markers like the CRP and procalcitonin, the area under curve along with the confidence interval for the of 95% for the calprotectin is considered to be 0.6 to 0.8 compared to the procalcitonin of having 0.62 to 0.82. So it can be considered to differentiate the bacterial pneumonia from the viral pneumonia. So hence, like the procalcitonin, the calprotectin is also being able to differentiate the bacterial infection from the viral infection. And maybe in the future, they can guide the initiation and de-escalation of the antibiotic therapy as the procalcitonin, which is being currently used nowadays. Considering the novel cytokine or the chemokine biomarkers like the interleukin 6 or the interleukin 7, the interleukins basically determine the helps in discriminating the sepsis from the controls, and the cutoff value is almost similar to the pentarixin 3 and the procalcitonin. It is said that the sensitivity of the interleukin 6 is 80.4% and the specificity is 88.9% in the patient with sepsis alone. And if we are considering the patient with septic shock, then the sensitivity is 76.1 and specificity is 78.4%. So basically, interleukin 6 was much discussed as a marker during the SARS-CoV epidemic. But again, its role in the viral infection has remained inconclusive, because it is said that maybe it is raised due to the ongoing inflammation. And further studies need to evaluate the sensitivity and specificity in distinguishing the viral against the bacterial infections. The interleukin 7, it is also a pluripotent cytokine which is being liberated in the patient with septic shock. The interleukin 7 is said to reverse the sepsis-induced lymphopenia, avoiding excessive inflammatory response. It has an anti-apoptotic property. It is required to restore the T cells and reverse the sepsis-induced depletion of the interferon gamma. So nowadays there are clinical trials where we are studying the recombinant human interleukin 7, which is the CYT107. And one of the first phase 2 trial was conducted on the vasopressor dependent septic patients, where the intramuscular injection of CYT107 was given in 2 doses recommendation, from considering low dose injections to the high dose injections. And it is said that it was well tolerated without any evidence of any induction of the cytokine storm or any worsening of the ongoing sepsis or the organ dysfunction. And it is said that the effect of the drug administration persisted for 6 weeks, and there was increase in the absolute leukocyte count and the circulating CD4 and CD8 T cells, almost up to 3.5 to 4.5 folds. post administration of the CYT-107, and only adverse effect they found was the injection site reaction. And so another second phase study is being ongoing to find out how to avoid this injection site reaction, and we hope further there can be a recommendation on the use of recombinant human interleukin 7. Coming to another markers like the monocyte chemoattractant protein 1, it is also inducing the oxidative stress along with the another markers, and by it is directly correlating with the sepsis severity and correlating with the other cytokine markers like the tumor necrosis factor alpha, interleukin 6, interleukin 8, and interleukin 10. Coming to another marker, that is a pentrexin 3. It plays a role in the early inflammation, activating the classical complement pathway and facilitating the pathogen recognition by the macrophages and dendritic cells. So a prospective study was done on 101 patients, comparing the sepsis and the healthy group and measuring the pentrexin 3, the monocyte chemoattractant protein 1, and the angiotensin 2 levels on the first day of sepsis. And it is said that all these biomarkers were significantly increased. And the coming to the second biomarker, that is the tumor necrosis factor. The tumor necrosis factor have two receptors, that is a tumor necrosis factor receptor 1 and the tumor necrosis factor receptor 2, which are released in the circulation to regulate the inflammation in the patient with ongoing sepsis. So basically, if we are detecting this soluble molecules, the soluble tumor necrosis factor receptor 1 and 2, and they might help in assessing the severity along with the other markers in patient of sepsis. So coming to the receptor biomarkers, some of the receptor biomarkers like the SUPAR, that is the soluble urokinase type plasminogen activating receptors. Basically, it has a moderate diagnostic value for the bacterial infection with an area under curve of 0.82. And there was a recent systemic review and meta-analysis done, which was involving almost 6,900 patients. And it is said that in that patient, it was in that paper, the diagnostic accuracy was almost similar between SUPAR and the procalcitonin. And the sensitivity of the soluble urokinase type plasminogen activator is almost 0.76 and specificity is 0.78. And it can help differentiating sepsis from the SIRS. Then considering the another markers like presepsin, it is also used for initial diagnosis and septic risk stratification, but there is insufficient evidence to support the presepsin levels. And CD64, it's an highly affinity immunoglobulin gamma receptor, which is expressed on the monocytes, eosinophils, and neutrophils, and it is said to rise within first few hours. And in 2019, a meta-analysis of 14 study was done, taking into account 2,471 patients, and the CD64 was compared with the CRP and PCT, where it was almost comparable. Coming to the other markers like the soluble triggering receptor expressed on the myeloid cells, that is the TREM1. They're basically distributed on the surface of the polymorphonuclear cells and monocytes, and they are upregulated by the bacterial lipopolysaccharides. So basically, the TREMs have a sensitivity and specificity of 0.8, and they are significantly higher in the patients who are non-survivors. And so we can consider the TREM1 along with the CRP and interleukin 6, but the drug candidate which is targeting this host immune response is nangibotide, which is a synthetic TREM1 antagonistic peptide that inhibits the activation of the TREM1 receptors and decreases the leukocyte activation, and hence it has a protective effect on the cardiovascular system and the survival by inactivating the immune host response. So there were two studies which were done. The study one was the considering the use of nangibolide in the healthy volunteers to assess its safety and tolerability. So nangibolide was safe and well tolerated up to highest dose of tested, that is 5 milligram per kg bolus dose, followed by 6 milligram per kg per hour continuous infusion for 7.75 hours. And there was no drug-related adverse event being observed or no anti-drug antibodies being detected. Another study, that is MOTC 107, was done. Sorry, this slide is not visible here, but it was considering the different doses of nangibolide in the patient with septic shock. The other toll-like receptors are used, and along with the biomarkers like PCT and CRP, that the program death receptors, it is a negative regulatory molecule which is highly expressed, and it is being identified as program death ligand 1 and D2, and it is responsible for down regulation of the T cell activation, and basically they are considered as an immune checkpoints. So the program death receptors, they have been identified to correlate with the SOFA score and has an independent risk factor for the 28-day mortality. The AUC was almost around 0.65, and it is the AUC of this combination model when compared with the SOFA score. It is based model predicting the 28-day mortality with a prevalence of less than 0.05. So basically the program death 1 receptor biomarker for the mortality, and it will need further study. So the antibody which is being currently studied against this program cell death protein 1 and the program cell death ligand 1 is nivolumab. It is basically a human monoclonal antibody of CD28 acting on the CD28 receptor, and it is said that it is decreasing the apoptosis and improving the immune T cell function, and it restoring the neutrophils and monocyte functions in the human body. So it is under the phase 1 randomized control trial. It was basically given in a dose increasing from 10 to 900 milligram, and it is shown that it is safe in patients with sepsis-induced immunosuppression. Even after the high dose of nivolumab, like 300 to 900 milligram, the HLA-DR expression remained high until 30 days, and there was no evidence between the rising of the acute lymphocytes and cytokines after administering the nivolumab. So the novel microcirculation related biomarkers are the angiopoietin 1 and angiopoietin 2. And basically the angiopoietin 1 and 2 are responsible for the vascular endothelial cell responses during the sepsis. And in a small study utilizing the sepsis 3 criteria, they were compared with the plasma levels of pentraxin 3 monocyte chemoattractant protein 1, and it is found that there were low levels of angiotensin 1 and angiotensin 2 were higher in those patients without sepsis. And angiotensin 2, it is directly correlated with the coagulation and the fibrinolysis indices. So the newer vasopressors, which is being currently studied, is celepressine, which is highly selective for the V1 versus the V2 receptors, more than, so it is highly specific for V1A receptors more than the V2 receptors. And it is known to prevent the microvascular leakage, and it is associated with the positive fluid balance in bovine sepsis. So in a phase 2 randomized control trial, it was almost administered in 53 patients with the early septic shock. It was well tolerated and allowed reducing the doses of norepinephrine and diminish the fluid balance and shorten the duration of mechanical ventilation. Recently, a phase 2b3 randomized control trials are going on evaluating the dosing strategies for celepressine. But in the recent 2021 guideline, it is a weak recommendation to use celepressine. Coming to another biomarkers like andromodulin and the proandromodulin. Basically, andromodulin is a 52 branch chain amino acid which is being produced in the endothelial cells and the vascular cells, and it helps in systemic circulation. So ADM is very quickly degraded and cleared from the blood. So it is very difficult to detect this andromedulin level by the standard immunoassay. But the levels of the mid-regional fragment of the promedulin, which is a byproduct of this andromedulin, it is easily measurable, and it is reflecting the levels of the andromodulin. So basically, this andromodulin, once detected, we are studying the adrisizumab as an andromodulin targeted therapy in the sepsis. So basically, it's also a recombinant monoclonal anti-ADM antibody, and the mechanism of action, it is relying on modulation of the ADM equilibrium between the blood compartment and the interstitium. So basically, this adrisizumab, it is restricted to the blood compartment, whereas the ADM, that is the andromodulin, it will freely diffuse between the endothelium and the extravascular space. So it is said that the presence of elevated circulating level of this andromodulin, the adrisizumab may shift the adrimodulin from the interstitium to the circulation, and hence reduces the adrimodulin mediated vasodilation. It has basically a dose dependent peak concentration, and in the recent phase 1 human trial was done to investigate the safety, tolerability, the efficacy, and concentration of there is an ADRIOS 2 trial which is enrolling 300 patients, and it is randomized to receive the adrisumab of 2 and 4 milligram per kg or placebo in 1:1 to 1:2 ratio. It has been completed, but the adrisumab has not been recommended by the recent guidelines.
Sorry to interrupt, Dr. Urvi. How many more slides to go?
Sir, the markers are being finished. Now only the antibodies and the antibodies and the extracorporeal blood purification techniques are remaining.
Srinivas, can we extend this to the next week, because we are close to close to an hour now?
Okay, sir, not an issue.
We'll take the opinion of Dr. Srinivas as well. Hello.
Yes, sir.
I think it was a exhaustive and very informative talk. I think we'll continue next week also, so that we take the discussion on the various aspects, newer emerging therapies in sepsis, the newer biomarkers, all the other aspects into conclusion next week. So Dr. Urvi will be joining us again next week. Please do log in again for completion and continuation of this topic. Thank you, Dr. Urvi.
Thank you, sir.
I hope it's okay with you for joining us again next week.
Yes, sir.
Yeah.
It will be.
Thank you. We'll see you all again next week.
Thank you, sir.
Thank you.